Hello students, this is Dr. Fitzgerald, and tonight is June the 28th. We are going to be talking about chapters 7 and 8, and I'm going to do a review for the comprehensive exams and a review for your midterm exams at the end of the hour. I am assuming that some others will join us, but maybe they've decided to take a study night or just a break. But I'm going to encourage them to listen to the archive. I do want to do just a few reminders and maybe give a few more people a chance to get here. Again, I want to thank you for submitting your chapter questions. There are, I see, 2 of you who do need to do that. Maybe you are in the process of doing that now. I also want to thank you for your discussion of Bobby and Drew on auditory training. We were evenly split in this class. Kind of half of you chose Bobby, who is certainly a much more challenging student to work with in terms of auditory training, in light of the fact that he has made slow progress even though he is implanted. Both of those boys were cochlear implant users. Both of them had a medical etiology of meningitis. But I think that always goes to illustrate the fact that if you just know what was the cause of the hearing loss, what's the degree of the hearing loss, what type of amplification or assistance do those clients get, you still are not able to predict what the outcomes will be, because all of our patients are unique, which does bring us to this discussion that we're going to have tonight on what is our role as SLPs in working with the population of individuals with hearing loss and deafness, and to think about the fact that while the otologist, the surgeon, the audiologist all have very important roles, it perhaps falls to us as the SLP to accurately assess our clients' needs and then design an intervention program that's appropriate for those needs. And so we're going to be doing some talking about that tonight. I do want to wish everyone good luck on comps on Saturday. And again, at the end of the hour, I am going to do a brief review of the comprehensive exam in terms of the AR section. I think you are all well prepared. If I were you, that would not be where I would put my energy, because you're in the midst of this course and you've just been diligent in completing your chapter self-assessments. So you have at least looked at the material and thought about it enough to answer some of those questions. I would concentrate on audiology. I would concentrate on speech science. And I certainly would concentrate on the things that Dr. Smith and Dr. Gibson have taught you. I also want to remind you that your midterm in this class is an online midterm. It's open July the 5th through July the 10th. So that will give you a little chance to take a deep breath after you take comps, for those of you who are taking comps on Saturday, and then have a little chance to take a deep breath and then take this online exam. It is a 20-minute, 120 minutes, a 2-hour exam. I'm going to go over it with you tonight so that you will be able to feel confident that when you open the exam. I do not know the answer to that, Kelly. That's determined by Dr. Smith and Dr. Gibson. I do as I'm told. It has, in my experience at TSU in 15 or 20 years, it's varied widely. From soon to before you graduate. I'm sorry that I can't answer that. Dr. Smith and Dr. Gibson are the persons that will make that determination. Let's see if we can think about this new section in our audiology textbook, in our oral rehabilitation textbook, beginning with chapter 7. It is sort of a whole new module. It's about communication, behaviors, and conversation. It begins on page 248 of your Nancy Time Murray textbook, Foundations in Oral Rehabilitation for Children, Adults, and Their Family Members. What I think I would like for you to come away from this module with is that there are more commonalities among our patients that have communication disorders sometimes than there are differences. I actually believe that this section of your textbook, the 4 chapters in this module, really have a lot to say to us about how we manage all of our patients with strokes, our patients with dementia, our patients with Parkinson's, our patients with other neurogenic disorders, our children with language impairments, our young people with traumatic brain injuries, our individuals with severe intelligibility issues, our individuals with fluency disorders in the sense of rhythm and rate disorders. Ultimately, as the World Health Organization reminds us, our goal is to have our patients functionally be able to communicate in the environments in which they operate on a day-to-day basis. And oftentimes, I think we as SOPs see the trees and we miss the fact that we're in a forest. We are so focused on individual phonemes, or we're so focused on syntactical structures or morphological structures. And those are certainly important. But we forget that we are mostly about helping our patients be effective in communicating with others. And that if we start by looking at communication styles and communication strategies and start from that larger holistic picture, sometimes we focus on what's the most important. And I think that is particularly true as our children become adolescents or young adults, or as our patients experience a communication disorder in later life, that we need to be thinking about how can we help them functionally communicate. And sometimes that's not the same thing as correcting each phoneme to 100% accuracy. And so as we talk tonight, I want us to try to, again, do some thinking about this broader picture. So that really comes back to the idea that Hearing health care is defined as care to provide individuals seeking relief from the effects of a permanent hearing loss. That is a hearing loss that is medically or surgically irreversible. But you might substitute our job as SOPs is to provide our patient who has aphasia from a stroke. It's seeking relief from the permanent effects of that stroke. Or a patient with ALS, it's seeking relief from the effects of that neurological disorder on communication interaction. So again, it's about focusing maybe on the big picture. And we do have to be reminded sometimes that if we think about our patients, we are thinking about our patients in a network of their families, other professionals that work with them, and we have to think about we are in a team-based relationship. So I want you to remember this definition. This is from the ASHA Working Group on Audiologic Rehabilitation. And it's been around for about 20 years, but it reminds us that AR, oral rehabilitation for patients with hearing loss, is an ecological, interactive process that facilitates the person's ability to minimize or prevent the limitations and restrictions that auditory dysfunctions can impose. You've seen this before. We've talked about it several times. But it's looking at the World Health Organization's model that ASHA says is the foundation for our SOP code of ethics, that we are focused on trying to prevent the limitations and restrictions that a communication disorder can impose on well-being and communication, interpersonal, psychosocial, educational, and vocational functioning. So that's really where our focus should be. What impact does this hearing loss have on a person's social, recreational, family, educational and vocational, if that's part of their stage in life? And so an audiologist named Ray Hull developed some principles of AR. And he said that AR should focus on the specific needs of the patient. That always we need to ask the patient's specific significant others, as professionals who work with the patient, what are the needs of the patient? And that's where we should put our focus. That's what we should design as the target of our therapy. And that we as clinicians should always be the model of effective communication. So we should make sure that we are using all of these principles of how do you make yourself easy to lip read? How do you make yourself easy to listen to? How do you change the environment in the therapy setting that you are in to make that accessible to the patient? And that patients need to not only hear what you think should be their goals, what you're working on in your treatment plan, but they should be formulating their own goals. And whether that's a child, whether that's an adult in a long-term care facility, it's not just about going in and telling the patient, Mr. Jones, today we're working on, or children, today we're going to work on. It is about asking that patient and those children, what are you interested in working on? We're going to work on this target because you said that was most important to you. You said that was something that really you wanted to focus on. So letting the patient choose their goals. In AR, in contrast to other communication disorders, it really is important to have both individual options and group therapy options. Thank you, Elena. Glad that you are here, Whitney. Sharon, glad that you, I know you've been in and been back. It is important that we have both options available. There are things that patients derive from individual therapy, but group therapy, in particular in AR, has been shown to be especially effective. And in fact, group therapy and partner therapy has been shown to be an effective strategy. So that means that we're not only focusing our AR on the patient, but we're focusing our AR on the partners of that patient, be that the staff that is caring for someone in a long-term care facility, be that teachers and peers in a school setting, be that a spouse or adult children of one of our geriatric patients. So it's important that therapy, again, be a much broader endeavor than just isolated individual therapy on a particular analytic auditory training or speech reading objective. It's also important that we look at counseling. And we're going to spend next week talking about counseling as it relates to these communication strategies. So we're going to spend, again, a good bit of time talking about what is counseling for patients with hearing loss, how do we do that, how do we counsel and not step across an important boundary and veer into another person's scope of practice. So we want to talk about what's our role versus what's the role of a professional counselor when the issues exceed our capabilities. We also are going to talk a good bit about this idea of assertiveness, a concept in AR that is really important, that we work to help our patients learn to be assertive in a communication environment. Not aggressive, not angry, but to assert their needs and to seek others to cooperate with them. So to turn down the television, to move to a well-lighted room. So patients should be encouraged to achieve a balance between being assertive and having realistic expectations for what does it mean to live with a hearing loss. We're going to talk next week a good bit about living well with hearing loss. That's a concept that I hope you all have encountered in your medical settings, that rather than focusing on disease and disability and illness, part of 21st century medicine is focused on well-being and health and helping individuals, no matter what their stage in life or what their particular disease is, helping them learn to live well with their disease, whether that's hypertension, whether that's diabetes, or whether that's hearing loss. So we're going to talk about living well with hearing loss, not making the hearing loss completely go away, not making it like it used to be before you lost your hearing, but learning to live well using all the tools that are available to you, all of the amplification technologies, all of the communication strategies, all of the specific therapies that are available, and to, again, live well with that kind of hearing loss. We are also going to be doing some talking, as Hull says, about looking at designing therapy activities that give our patients the opportunity to have positive interactions and communication experiences. Many individuals with hearing loss develop very low self-esteem. They feel ineffectual. They withdraw from social communicative interactions because they are so difficult for them and they are so ineffective. And that produces this downward spiral. They become submissive, they become unwilling to interact, they become isolated, they become depressed. Our job is to make sure that we are giving them strategies, we're giving the people in their communication environments strategies to make those communicative experiences positive, to show them that they can be successful communicators even with a hearing loss. And that too applies to our patients with other kinds of communication disorders. It applies to our fluency clients. It applies to our clients with cognitive, communicative, linguistic disorders. It applies to our patients with severe dysarthrias or apraxias. We may not be able to cure them, but we want to provide them opportunities to interact effectively. We certainly use AR therapy as a place to try out assistive listening devices and other technologies so that patients get to see that there are simple assistive technologies, hearing assistive technologies that might help them. We certainly want to make sure that we are looking at ways to screen hearing as well as screen vision, alerting other caregivers that vision and hearing interact, this auditory visual enhancement. And then we teach specific communication strategies for those times when the environment is especially difficult, or the patient says, talking on the telephone is really hard for me. Talking in a noisy restaurant is really hard for me. So we actually go through those kinds of situations and talk about what alternatives could you use. Again, it is critical that we look at the patient's family, their friends, others that they interact with, and that they become targets of our AR plan. So with some of those 14 principles that Ray Hull kind of has in mind when we talk about AR being an interactive ecological process, let's talk about what are the components of an AR program. First is the communication history. And again, you may say, well, the audiologist diagnoses the problem. I just treat it. That's actually untrue. The audiologist diagnoses what is the medical condition and the audiometric results. But you, as the FOP, are the communication specialist. So you do a communication history of your patient. You do an assessment of their communication skills that we're going to talk about tonight. Their communication fluency, their interactions and conversation. The audiologist will assess their hearing, select amplification, dispense the amplification, and do a quick orientation to how do you use your your implant? How do you use your hearing aid? How do you use your but as we've talked about, we as SLPs oftentimes have to come back and tell our patients how to manage that hearing aid again. We have to check the devices. We have to train our patients and their significant others about how to replace that battery, how to do the Lean 6 sound test, how to note when the device is working or not working. And then we do specific communication strategy training. We're actually going to train them to problem solve the specific situations that they tell us are hard for them. It may involve auditory training. It may involve speech reading. For children, it clearly, in most every case, will involve speech articulation therapy, language therapy. It may involve working on their voice quality. We will be doing counseling as a part of our AR program. We are helping our patients through informational counseling. Simply, what is your hearing loss? How does it affect you? How do you explain it to others? That's why we use the count the dots or the familiar sounds audiogram to make sure that our patients understand the nature of their hearing loss. They understand what benefit they should expect from their hearing assistive devices and what benefit they are not reasonably expected to get. They don't get 20/20 hearing back. Sarah, I thought your comment about your geriatric patient was right on point last week. When you realize what one hears through a cochlear implant, sometimes it's really just astounding. It's not 20/20 normal auditory hearing. It's quite different. It's a very useful signal. Patients make use of it to decode language well. But it's not what it used to be if a person has had normal hearing. So again, part of our job is that counseling, that information giving that we can provide. We also provide personal adjustment counseling. And I think that too is something that we go, well, I'm not trained. I can't do that. But indeed, when it relates to a communication problem, who better than you as an SLP who is an expert in communication, who better than you to do some counseling about adjusting to a new reality? Sarah, I think that's right. I think oftentimes that physicians, audiologists even, just don't mention to the patient, it's going to sound different. It's not going to be like you remember sound before. To families of children with cochlear implants, we oftentimes don't say, we neglect to say, we sort of omit saying, this is not like we just turned up the volume and now your child hears like his sibling or like you hear. This is quite a difference. And while we don't want to emphasize the negative, we want them to use that device. We want them to understand that full-time use of cochlear implants or a BAHA or a hearing aid is critical, that it's a tremendous help over not having a device. It's not the same as normal hearing. And so sometimes I think as audiologists, as physicians, professionals tread lightly on introducing the idea of it will be different. It won't be like you used to hear if you've had a sudden hearing loss or an acquired hearing loss. And that, I believe personally, leads lots of patients to be very upset and angry. Their response when it's not like it used to be is either this device doesn't work, it's a bunch of junk, and I paid a lot of money for it, or there's something the matter with me. And again, that lowering of self-esteem. Even with this device that costs a lot of money, I still can't hear. What's the matter with me? And that part of the counseling is within our scope of practice. Helping patients of any age come to grips with that this is the new reality. And to get to that point of, I live well with hearing loss. I accept that it is not normal. But I have strategies that I can use. I know how to problem solve when I'm in a situation where communication is not fluent and easy. So again, I'm not suggesting that you step across a professional boundary. And we're going to talk more about this next week, particularly in Chapter 10 in our book. I think it's also important to realize that one of the most effective components of an oral rehab program are these peer support groups. Because seeing someone else who is coping with a hearing loss, who has some experience with what works in a noisy restaurant, what works talking over the telephone, having experience of another parent in a parent support group for parents of children with hearing loss. Seeing how someone else solved whatever the problem is oftentimes is encouraging to individuals to say, if they can do it, I can do it. Or, I had never thought about that. It's not that all of these peers always have an answer or always have a good answer, and that's why we are in those peer support groups to make sure that it's not misinformation that one peer is communicating to another peer. So it's not simply put parents together in a room, put spouses together in a room and let them share horror stories or let them vent. That's not what I'm talking about. I'm talking about a monitored, well-led group with an SOP there to help the group function well as a support group. When we talk about communication strategies, training, and assessment, particularly Chapter 7, communication strategies training is the instruction that we provide to a person with a hearing loss to help them maximize their communication potential. And it might include auditory training, speech reading training, speech and language therapy, per se, particularly if it's a child with a hearing loss, and communication strategies. Communication strategies is a course of action taken to enhance communication. So that's what we're going to be focusing on tonight. And one of the things that we need to do is we actually need to take a step back and look at conversations. Because most communication occurs in some sort of conversational context between a parent and a child, a teacher and a student, two adult peers, spousal partners, a person and a physician or another healthcare provider. And all conversations are controlled by implicit rules that guide the participants in how to choose a topic, how to maintain a topic, how to take turns. And while we study that probably in our language disorders classes, it applies equally, or maybe even more so, to our adults. And Erber talked about the fact, and there's a fair amount of research that says if you look at the conversations of people with hearing loss, there are oftentimes very significant deficits. And again, sometimes we haven't been as careful in addressing those as we have in addressing phoneme disorders, morphological disorders, sentence structure disorders, vocabulary deficits. But it's very typical to see that the conversational weaknesses in persons with hearing loss include disruptive turn-taking, a modified speaking style, inappropriate topic shifts, very superficial content. How are you? Fine. Very frequent use of clarifications. Huh? What? Excuse me? Say that again. And violation of implicit social rules. And it's in fact some of these conversational weaknesses that actually are very problematic in our hearing impaired population's overall conversational fluency and their success in conversational activities or life events that involve communication and conversation with others. So when we think about this ecological model that Asha is encouraging us to use, we need to recognize that, again, it's a talker, it's a message, it's a receiver, our patient with a hearing loss usually, and it's the environment. And all together, that makes the ecology of this communication event. And we can intervene on any one of those particular aspects. Any one of those is a therapy target. So I want to encourage you to look at page 255 in your textbook and think about, okay, if I can't fix my patient, I can't fix the receiver, maybe I can make some changes in the talker. Maybe I can look at the frequent partners and I can teach them how to communicate more effectively with my patient, who indeed does have a disorder. Maybe I can teach others to tailor the message, give a key word, use simple vocabulary, use simple sentence structure. Maybe I can change the environment. Maybe I can instruct both the patient and the conversational partner to move to a room that's quieter, use full facial clues, reduce the noise, use an FM system. So there are lots of ways to improve the communication system, and that AR should be focusing on the system, not just, can I fix the patient? So again, there are instructional strategies where we teach the communication partner to change the delivery of the message, to slow down, to offer a forced choice. Did you watch TV? Or did you read this afternoon? So you've given them a much more constrained set of parameters. We can, again, change the communication environment, reduce the noise, ensure full face cues. We can help the patient by developing attending strategies. So we teach the individual to pay attention. Pay attention not just to the facial cues, but to the linguistic information, to the situational context, so that the patient can at least infer or guess at, fill in the blanks, get the gist of the message. And we need to be saying, that's okay. We can help kids in classrooms. I always teach them slant. Has anybody taught you slant? It's a listening or learning strategy. Anybody know what slant is? Slant is a way to help kids in classrooms sit up, pay attention, and actively listen. It's just a little mnemonic device like so many of the learning strategies. It's sit up, lean forward, attend to the talker, note important information, and track the talker as they move around the classroom, around an environmental area. So teaching kids with hearing loss, it's going to be harder to listen in class for you than for your brother or for your friend. You are going to have to sit up, listen. In is note important information. So what's the teacher talking about? Is the teacher holding up the social studies textbook? This must be about social studies, not math. Nod your head. Sometimes that is a strategy. That's a strategy of nodding your head, meaning you're giving the speaker input saying, I'm getting it, pay attention to me. But it does have a lot of variations because it's been around for about 20 years or so. But any of those attending strategies, it's important to teach our kids that. It's important to teach our adults. This is not going to be easy. I mean, that's a realistic expectation. So you're going to have to attend. If you're going to a lecture about something, it might be well to read up on it, whatever the subject is, so that you recognize key words. Teaching our clients another facilitative strategy, which are called anticipatory strategies. It's sort of learning about the topic, learning about the background. In schools, we do that all the time. We teach kids the vocabulary in our therapy that they're going to encounter in the classroom. So we pre-teach the vocabulary. So again, you want to look at that, the strategy on page 258 in your Time Murray text. Ready, set, go. Again, it's about learning what are going to be important words that might come up. What are current events that might come up. So that the person is better prepared to use those things that we call top-down strategies, cognitive strategies, when they miss the detail of the auditory or visual event. So when they don't hear the message clearly, they can't lip read the message clearly, they can still get the gist of the conversation by using some of these anticipatory strategies. We also have to teach them repair strategies on page 259 in your text. There's a lot of research out there that says that hearing impaired individuals use a lot of non-specific repair strategies. Huh? What? Pardon? That quizzical or confused look that gives their partner information. I'm not getting it. I didn't get it. Say it again, in effect. But it's more helpful if we can teach our patients to be specific about what they are not getting. So request that the partner repeat the message. I heard you say you needed a tablespoon of something. What was it that you needed? So telling your partner, here's what I got, here's what I didn't get. Making sure that the partner knows to rephrase the message, to simplify the message, to support the auditory cue with finger spelling or with a sign or with a gesture. So looking at those repair strategies, and again, it's not just your patient that you teach those for, it's sometimes the partners. Another thing we want to make sure that our patients understand is that they can detect when a communication repair is needed. So are they aware of the breakdown? And then can they choose a course of action? And what we often see is our hearing impaired patients, kids as well as adolescents and adults, often do not choose to use a repair strategy. If I use a repair strategy as a person with a hearing loss, I am acknowledging that there's a communication breakdown, that I didn't get it. I may have to acknowledge that I have a hearing loss, and then people look at me differently. There's a lot of research that says that patients with hearing loss sometimes don't want to acknowledge the hearing loss, because then the conversation turns to, oh, you have a hearing loss? Well, tell me about it. And the whole tenor of the interaction shifts from, well, we were talking about the movie that you went to see last night, and all of a sudden now we're talking about me and my hearing loss, which I don't want to talk about. Does that make sense to you? So we see patients, again, being very hesitant sometimes to use these communication repair strategies to admit that they have a hearing loss. And so what do? They disregard the utterance. They simply ignore it. Or they do what we call bluffing. They move on, they make up something, even if they've got it wrong. So we want to encourage our patient that bluffing is oftentimes not an effective strategy. We may want to, at first, when we see that in our patients, we may want to accept it, understand it, be empathetic with. I might do that too. That's an understandable reaction, but it's not an effective problem-solving reaction. So we want to get our patients to the point where they can use more effective tactics. So far, we've been talking about receptive repair strategies, what to do when our patient doesn't understand a message that's sent to them. But we also see that there are expressive repair strategies. So those are the strategies that are used by the sender to try to repair an unintelligible utterance. And we frequently see that it's the parent, the teacher, the peer who receives a message from a person with a hearing loss. Again, often a child, it's unintelligible. So the patient's expressive communication was unintelligible. So what do? Oftentimes we see parents and teachers who simply fill in. They interpret. They override the poor, unintelligible communication by the child. What happens is then children with hearing loss become adult dependent. They're used to having a parent interpret for them, ease the communication situation. And they don't take personal responsibility for doing their part to repair. Now that's a fine line, and those of you who have children, particularly those of you who have children who may have some exceptionality, some disability, know it's a fine line between how hard you push a child to be independent, to resolve their own problems, and particularly if the child has special needs. So again, as clinicians, as therapists, as parents, we all have to make those judgments on a day-to-day basis. But one of the things that we know is that children with hearing loss oftentimes are not successful in integrating into inclusive or mainstream settings, and it actually has not very much to do with their cognitive skills or actually their speech and language skills. It has to do with the fact that they aren't assertive, that they don't know how to repair, that they don't know how to engage in social interactions with their normal hearing peers. So we want to begin to help children with hearing loss from very early on learn expressive repair strategies. That means helping them learn that they have to slow their speaking rate sometimes. They have to, in effect, use shorter sentences. They have to use more precise articulation. They have to emphasize key words. They have to be part of the solution. They can't expect mama, the teacher, their sibling, a good friend to always solve the problem for them. So we need to, what I call, up the ante, raise the requirement. When someone doesn't understand you, when someone looks at you and says, huh, or tell me again, you need to think, okay, what do I need to do as a person with a hearing loss? I need to slow my rate, to use more precise articulation, to emphasize a key word in my message, to use a shorter sentence. So again, it's a two-way street here. If we look at the research on repair strategies, the most common repair strategy is the repeat repair strategy. That's the first thing little children do. When you look at them and you don't understand what they say, and you say, tell me again, that's exactly what they do. They simply repeat When they don't understand, the most common repair tactic is what or huh. And so we need to help them move beyond those very fundamental, basic repair strategies to the ones that are more effective, rephrasing, looking at these more precise articulation. We know that the research tells us that individuals with hearing loss who learn to use these strategies report that they actually feel less frustrated, that they're less likely to avoid social communicative interaction situations than those who don't use these strategies. We know that individuals who have experienced a sudden loss may need to use those strategies more. That individuals who experience that gradual decline in hearing, such as many of our geriatric patients, kind of fall into some of these strategies, at least some of the time on a gradual basis. There's some pretty interesting research that says that only about 44% of patients actually reveal to their communication partners in a casual, social, or vocational, or educational context that they have a hearing loss. Now, that doesn't mean they don't tell their spouse or, someone that's very close to them. But in most of their day-to-day interactions, they simply don't reveal that they have a hearing loss, because once they reveal the loss, the conversational topic may shift to the hearing loss itself, not what they were talking about. So again, we want to look at how we can help patients be assertive, appropriately assertive, not aggressive, how we can help particularly our CI children, who are our shining stars, who are doing well, how we can, as I always say, put the frosting on the cake. My analogy always is that we as SLPs are so busy mixing and baking the cake. We worry about articulation. We worry about language. We worry about vocabulary. We worry, and we are so busy mixing up and baking that cake that when it comes out of the oven and they are within the broad limits of normal, we go, whew, look, they are within the broad limits of normal or near normal. And we go, time to dismiss them. Or we see an adult with a hearing loss and perhaps using some amplification, and we say, well, look, he's got a hearing aid. He's going to do okay. But the truth is, we forget that that cake needs some icing or some frosting. That person needs to be able to use those good speech and language skills in normal social interactions with familiar communication partners. And our work is not finished if we have not assured ourselves that our patients are able to use the skills that they have acquired in our therapy in these communication situations. So we have to assess where are they in conversational situations, in daily activities that they tell us are important to them. Nancy Ty Murray spends a good bit of time helping you decipher these different conversational styles. And there's been a lot of research on conversational styles and behaviors. We're on page 273 in your textbook. And we're looking at the fact that much of the research can help us begin to look at which kind of constellation of behaviors, which kinds of styles does our patient have. Is our patient passive, tending to withdraw and avoid interactions? Is our patient demonstrating an aggressive style where our patient tends to blame others for the misunderstanding? They all mumble. They don't talk clearly. Or is this a person who has been able to develop an assertive style, where the individual with a hearing loss takes responsibility for managing the communication difficulty and is considerate of their partner? So we are trying to look at developing in our patients an interactive behavior constellation that includes these tactics of an assertive style versus that non-interactive avoidance passive style versus that dominant pattern. So if you'll look at figure 7-6 on page 276, you'll see just sort of a little Venn diagram of those. But part of our job in therapy, part of our diagnostic or assessment process, is to see our patients in conversational interactions with us, with another peer, with different partners. So our ability as SOPs to look at these basic conversational patterns, look at these communication strategies, help us then design an assessment and a treatment plan that's going to focus on, again, what the real deal is, what the real problem is, and to help the patients, be that as an adult or a child, and their partners manage those communication difficulties more effectively. Again, within this environmental, ecological approach to oral rehabilitation, which is functional, which matches with the World Health Organization's model of functional outcomes. So when we think about that, part of the answer to that is using Shao and Nierbrandt's core and care model, because that is in fact what it does. Core is an assessment model and care is an intervention model, helps us focus on this more functional approach to AR. We've been over this a million times. Our job is to assess our patient's communication status. The audiology report is going to help us. Medical records are going to help us. Educational, psychosocial reports and a child's cumulative educational records are going to help us. But assessing the communication status, both what is the impairment and then what activities does that limit our patient, our student from participating in, is our job. That's the SOP's role. So we have to assess auditory, visual, language, manual communication. We can do that through self-report. We can do that through norm reference standardized tests. We can do that through observational assessment. We can do that through communication/language assessment. One of the things that we oftentimes find ourselves using in working with adult patients is to try to come up with some sort of quick and dirty screening tool that lets us look at a bunch of that and to predict which of our patients, as adults in particular, or older adolescents, college students, which of them are going to need more direct intervention versus which of them are going to be fine using their hearing aids, their BAHAs, their cochlear implants, and can maximize their communication skills just with that technology. And if we think about that, there are a number of tools, and our textbook is just full of different tools. The hearing handicaps for the elderly, the hearing handicap scale for adults, many of those different kinds of assessments. But oftentimes I find that when we're in long-term care settings or we're in even busy clinics, one of the things that we see is that people say, I need something quick and dirty. I need a screening tool. And so I want to encourage you to look at a screening tool that was developed by Al Penner and Medlin, and to think it's quick and dirty. It's available online. It literally was part of an article that was written some time ago. Came out of the VA in Denver. Again, it's an older tool, but it's easily available. It's the Al Penner Medlin AR screener, and it has a few items of self-assessment where the patient says, what is hard for me in several situations. It then looks at auditory skills, and it looks at visual or lip reading skills. And it helps you go, okay, I now see that here's my patient. My patient is having difficulty with certain aspects. So it takes some items from the hearing handicapped inventory. It takes some items from lip reading tests, the Denver quick lip reading test, and some items from an auditory discrimination test. And individuals who do poorly on this little screener, the Al Penner Medlin auditory screening scale, are people that need therapy. The results out of a big VA study said that screening scale could differentiate between those individuals for whom simply putting on a hearing aid works. They don't need anything else. That use of a hearing aid is sufficient to alleviate their communication difficulties versus those individuals who are going to need additional AR. So again, it's quick, it's efficient, it's free. That's important. That it will help us, and it's certainly something that we can, as SOPs, use, for example, in a long-term care setting. So I encourage you to think about our job is to do communication assessment. It's also then to think about reading our patients' medical records, looking at the participation variables, looking at those related personal factors, particularly this thing called attitude types. So we'll definitely be looking at motivation for participating in therapy. And we'll be looking at environmental factors. And then as we start to develop a treatment plan for these people who appear to need more than just a hearing aid, just a cochlear implant, just a BAHA, then we're going to talk about counseling and psychosocial information. First, sometimes providing them with interpretation of the audiogram. information about what the audiogram means, counseling, guidance, helping them come to some acceptance and understanding, and then to set realistic expectations and goals to live well with a hearing loss. And then we are going to focus on supporting our audiology colleagues in terms of helping our patients use their hearing aids, their cochlear implants, their BAHA, their various assistive devices, repeating if necessary, showing and telling, demonstrating the different types of troubleshooting, hearing aid checks that the patient or a significant other in their lives can go through. This Saturday when you come to take your comp, I'm going to ask Dr. Matlock, in the midst of her quick lab for speech science, to show you some of the commercially available hearing aid check kits that you can purchase for your school, for your long-term care facility, so that you can do the full hearing aid check with a hearing aid, with a Spth, with a battery tester, so that you can make sure that the amplification devices that your patients are using are working. And then we do management. Our care R is remediate communication activity. And so we're actually going to work on tactics to control the situation, this philosophy of realistic expectations, and then personal skill building. So that may be we're going to include auditory training, speech reading, speech language training if it's a young child who's going to need additional experience. One of the techniques that we often use as what I call quick and dirty, one-page handout, 1 hour of counseling for patients is this strategy called CLEAR, C-L-E-A-R. Again, a mnemonic device. It's different from Nancy Ty Murray's CLEAR online software to train auditory training and speech reading. This is simply a reminder for our patients to control your communication situations, look at or lip read the talker, set realistic expectations for what you can or cannot do in a particular communication situation. Be assertive to help other people understand your hearing difficulties, and use those repair strategies for breakdown. So oftentimes, literally, if you only have an hour with a patient, teaching them these things and giving them literally a one-page handout and this mnemonic device oftentimes is at least some intervention. Oftentimes suggests that this works in talking with a group of patients in a long-term care setting. You're not going to provide hours and hours and hours of AR therapy because it may not be reimbursable, or your facility has other jobs that you are supposed to be doing that are for sure reimbursable, like swallowing therapy. But you will have an opportunity at some point in time to spend a little time teaching this CLEAR technique. Similarly, if you have any access to your patient's communication partners, the CNAs that work with your patient, the other professional healthcare staff that work with your patient, if you have any opportunity to see your patient's family members, you teach them speech. Again, quick, dirty, one-page handout, 1 hour broken maybe into 3 15-minute segments of teaching the partners how to ease this communication, spotlighting their faces and make sure their face is fully visible, pausing between thoughts, because it's in that pause time that our central auditory nervous system actually has time to process. And particularly for our patients who are geriatrics, we know the speed of processing is one of the significant problems that they have with auditory comprehension. So they have slow processing time. We document that. Pardon me, somebody's got an open mic. If you've got a mic open, see if you can mute your mic. Or if you need to ask a question to the class, please just do that. Again, speech is the one-page handout, the 1 hour of AR for partners. Spotlight your face, pause between thoughts, emphasize and be patient, rephrase. So when the patient doesn't understand, you rephrase your message, you emphasize key words. Ease the listening strain by getting attention first. Oftentimes this is critical with our patients in early stage dementias, just like it's critical sometimes with our children. Make sure they are paying attention. You do that by calling their name. Mr. Jones, I need you to look at me. Bobby, we're getting ready to move to our social studies lesson. So again, using a name heightens a person's attention, and then you can communicate your message. Control the listening environment. So again, making the partner equally responsible for moving to a place that's quieter, using full face visual clues, reducing background noise by turning down the television, and then having a plan. Make sure the partner knows if there is a breakdown, how can I, as a communication partner, improve the situation? So again, clear and speech are these kind of 1 page, 1 hour, maybe broken into 4 15-minute segments, just short interventions. So again, the care model then does emphasize as its last E element, the environment, making sure that we have paid attention to coordinating and looking at what can we do, whether we're in school settings, whether we're in long-term care settings, for example. How can we encourage the powers that be that the school board, be that the director, the healthcare administrator, how can we help them see that part of helping their residents or their students is to create more favorable environments in terms of acoustic environments. So it's this idea of coordinating services between the family, the providers, and the setting. And that we're looking at a total rehabilitation effort at both the core assessment level and at the care management levels. So one of the things that we oftentimes do is we do these tips for a person with a hearing loss, tips for communication partners, assertiveness training, environmental modifications, not thinking that AR is ongoing long-term therapy, particularly for our adult clients. For our children, it's incorporated into speech and language and listening training. So again, having specific guidelines to work with the listeners in terms of what they can do, making sure that we are training our hearing impaired persons not to bluff, always having realistic expectations, paying attention, observing the talker, that we're training the speaker how to talk to get the listener's attention, slowing down, rephrasing, restating the topic, all of those things that we've been talking about, and it seems second nature to us because we are SLPs, and our companion discipline, audiology, has reminded us that these are the important things. But even though they're self-evident to us, they may not be top of mind to a teacher, to a parent, to a CNA, and to other healthcare professionals. When we think about our adults who might be going into the work setting, which is a population that many of you, at least in your TSU mandated field experiences, probably haven't had a lot of experience with, that working age adult. It is important that we help them look at what are the kinds of demands that are in a job setting. What kinds of requirements are they going to have for use of the telephone, meeting customers face-to-face, participating in work team meetings, so that we identify the hearing-related tasks within that job setting. We consider the environmental barriers that they are likely to encounter. We talk about the legal requirements under the ADA, the American for Disabilities Act, and Section 504 of the Vocational Rehabilitation Act, the federal statutes that require that employers provide accommodations and modifications for otherwise qualified employees. We talk about technology that can be used on the job, and that we make sure our patients are knowledgeable about that, and that we refer them, if necessary, to a vocational rehabilitation counselor to do more detailed job analysis and training. Again, we work on this idea of assertiveness training. That becomes a significant aspect of our care model. We work on environmental management. So SLPs play a significant role in the assessment and delivery of services. Using that core and care model in a team-based approach, we can contribute to the welfare of our clients and their significant others across settings. Let's take just like a 5-minute break. I'll stay on the line if any of you have questions, and we're going to come back and quickly run through Chapter 8, which is how do we do this assessment of conversational fluency and communication difficulties in a meaningful way. And then we're going to do a review for your comprehensive exam and for your online midterm. So I will be right here, but please go get something else to drink, take a deep breath, and we'll meet back right at 7:05. That'll give us a few extra minutes. So we will meet back at 7:05 after we take a quick break. Hello, everyone. It's time for us to get started again. We're going to now be talking about Chapter 8, Assessment of Conversational Fluency and Communication Difficulties. But I do want to, and then we're going to do a review for the comprehensive exam and a review for the online midterm. Does anyone have any questions about what we have been talking about so far? Everybody good to go? Okay, well, let's see if we can whip this into shape and keep working. Again, we're in Chapter 7 in your timery text. It begins on page 285, and then we're going to keep kind of plugging through. One of the things that we want to think about is that when we talk, as we talked earlier tonight, about looking at our patients with hearing loss, it is important that we take a more holistic view, a more interactionist view, a big 30,000-foot view of our patient and their communication difficulties. So we want to be looking at all of the aspects that go into communication difficulties that our patients might have. So when we think about that initial assessment, it really is important that we focus on the communication demand placed on our student or our adult patient in their everyday lives, and that we evaluate the impact of hearing loss on these daily activities. We've talked and talked and talked about it. It's this idea of thinking about how does the hearing loss impinge on the individual's ability to participate in the normal activities that others of the same age and station in life would participate in, and to identify those settings where communication problems arise, and then to document the kinds of social activities that the person is likely to engage in. To think about, is it employment, is it school, is it recreational settings, is it personal family relationships? And so it's certainly very true that all of us want to know what the patient's audiogram looks like, both their aided audiogram and their unaided audiogram. We want to assess the patient's ability to recognize words in auditory-only conditions and in auditory plus visual conditions. And so we are likely to be using that lexical neighborhoods test that we talked about in Chapter 2 on page 79. Or if it's children, we might use the children's auditory visual enhancement test. We might use one of the lip reading tests, the Utley sentence test, the Denver quick test, or that thing we were talking about earlier tonight in class, the Adler-Mellon auditory rehabilitation screening tool. So those are good things to do. We certainly are going to collaborate with audiologists in fitting for children and adults. We're going to be talking about amplification devices, hearing assistive technology, but the real thing that we do is this detailed communication assessment. So while the purpose of the audiological assessment by the audiologist is to quantify and qualify hearing in terms of degree of hearing loss, the type of hearing loss, the configuration of hearing loss, we then need to do an assessment that's going to let us target intervention objectives that can improve the patient's communication skills in functional settings. So it's important for us to think about this idea of conversational fluency and hearing-related disabilities, because any communication strategies training program begins with an assessment and it ends with an assessment. We do pre-testing and post-testing to evaluate whether we've met our objectives. When we think about what is conversational fluency, we have to be thinking about it involves things on page 287, like the amount of time that's spent in repairing communication breakdowns, the ideas and information that are easily exchanged between the participants, the share of speaking time, who speaks the most, the time spent in silence, is there an awkward pause? So when we think about fluency, it's those aspects that we are thinking about. How do we measure conversational fluency? We look at something called conversational turns. That's the period during which one of the conversational partners delivers a contribution to the conversation. That might be when they start speaking or start signing, and the turn ends when the person stops talking, stops signing, and someone else responds to the remark. We can actually do, again, a quick and dirty measure of conversational fluency, which has been shown in the research to hold up reasonably well by computing something called the mean length of turn and the mean length of turn ratio. So we are going to compute the average number of words spoken during a set number of conversational turns, or the average duration of conversational turns in seconds. So we can compute this thing two ways. We can simply compute number of words spoken, or we can do number of seconds that the person's turn lasted. And then we do the same thing for the other partner. How many words did they speak during a set period of time, during 2 minutes of conversation, during 5 minutes of conversation, over a conversation that extends for 5 conversational turns or 10 conversational turns. So we do the number of words or the number of seconds for each partner, and then we simply form a ratio. We look at parent, child. We look at spouse, our patient. We look at our patient and his CNA, or another participant in the long-term care setting. We look at student 1 and student 2, 1 being our target student. So we can compute these really simple statistics. If you look on page 288 in your Time text, you see 2 examples of how one might do that. One is a conversation between Anne and Joan. And when you compute that, Anne's mean length of turn in words is 8. It's a really short sample. She only had 2 utterances. She produced 16 words in total. So 16 divided by 2 is 8. Her average number of words per turn is 8. Her friend Joan, or friend Anne, produced 18 words in 2 utterances, so her average words per utterance was 9. If I take 9 and divide it by 8, I get close to 1. 1 would be where the 2 partners are absolutely equal in words spoken per term. Or if I had done it in seconds, I could have done it that way. If you look at sample 2 in your textbook on 288, you see Tom and Martha. That little excerpt presents a sample of low conversational fluency. Tom and Martha are talking, and Martha says, "Has your new furniture arrived yet?" And Tom says, "Huh." Martha says, "Your furniture." And Tom looks around and shakes his head. Martha says, "How are you doing? How's your wife, Mary?" "Fine," says Tom. If you look at that conversation, that is not a fluent conversation. That's a situation where Tom has multiple, and Mary have multiple breakdowns. The conversation is very superficial. Martha is speaking much more than Tom. So that's not an uncommon example among our individuals with hearing loss and their significant partners. The conversational fluency of the sample is filled with awkward pauses, no equality between the 2 partners. And you go, well, that's self-evident, and that's true. It is self-evident if you watched a video of that, or you transcribed that. But the advantage of doing this statistic, the mean length of turn ratio composed of the mean length of speaking turn in words or in seconds for each of the 2 speakers, is that it gives you some hard data, a number to say, here's where this conversational dyad, my patient and a significant other, were at the beginning, a pretest, and then I'm going to do some training, and here's where they got to at the post-test short sample. The advantage to this is it's really short, it's easy to compute, it provides data for the results of your intervention. Now, it's also true that you can use a computer software program called Dialogue that's discussed in your textbook that will help you do this, just like SALT, the systematic analysis of language transcripts, helps you analyze language transcripts. But mostly, because this is so simple to compute, most of us don't use that software. We are talking about really short samples. We are talking about simply taking enough data to document the results of our therapy, but to give us a database to do that, to make a statement. So when we see these non-fluent conversational fluency measures, we know we have a problem. We are looking at a situation where our hearing impaired individual typically is the one who has low output. The partner is taking the major responsibility for carrying the conversation. That is typical in parents and in teachers who interact with children with hearing loss. It's also typical in some spousal pairs. But the opposite also occurs, where the person with a hearing loss tries to control the conversation. They talk all of the time. They take up all of the space talking, so they don't have to listen or speech read, because that's what's hard for them. They have that very aggressive style. They monopolize the conversation, which is a way of deflecting attention from the fact that they can't understand you when you ask them a conversational question. So you do get the opposite, where the hearing impaired person is the dominant person in the conversation. That's equally problematic. What we see in typical conversations most of the time is a balanced turn-taking. Now, there are lots of things that can influence how a conversation goes. But in general, we want two communication partners exchanging information with ease, sharing responsibility for introducing topics, maintaining topics, advancing the topics. We don't want to see, or we consider, a disorder of conversational fluency when the discussion is superficial. How are you? Fine. What about the weather? Good. Or there are multiple breakdowns. Huh? Pardon? I didn't understand you. So it is simply a simple measure. It is true that conversational fluency as a way of assessing progress, as a baseline measure and a post measure, can be challenged, because it does depend on the conversational setting, the situation, the function of the communication partner. It can be problematic because maybe it's going to vary with the topic under discussion. It also can be a problem if that's your only assessment tool, because sometimes a communication difficulty doesn't arise during the conversation and you have no way to capture what happens in a breakdown, what were the tactics that are being used. But in general, if you set up the pre- and post-test situations that are similar in terms of the conversational setting, the situation, the partner, you can resolve some of those issues. Ty Murray also talks about in your textbook some other kinds of tools that we as SLPs would be using to assess our patients, including interviews, questionnaires, a daily log, group discussions, structured and unstructured communication interactions. So we are looking at those tools that she is going to talk about, and there's a little table on page 290, table 8-2, that talks about what assessment tools do we have. Interviews. Obviously, interviews are a straightforward assessment procedure. You let the patient tell you about their conversational problems or issues. You ask the patient what they think are the reasons why breakdowns happen. One of the advantages is you're getting specific information from that patient about his or her difficulties. You're getting information that can help you design a targeted, individualized program. But it doesn't allow you to quantify that. You don't have a baseline measure. It is important that you think about how to interview a patient, how to interview partners of your patients, so you can learn as much as you can about the patient's perception of their communication difficulties. And you're also, if possible, going to be interviewing the partners. So you're going to interview the parent of the child, the teacher of the child, the spouse of a married couple, other healthcare providers that work with your resident in a skilled nursing facility or a long-term care, so that you get their perception. And sometimes those are congruent. They both see the same things. Sometimes they are very different. Sometimes the patient thinks they're fine, and the spouse or the healthcare team sees clear problems. So you get a sense of what are the factors that you're going to be working with. The other option, other than conducting an interview, where you are using this technique that Ty Murray talks about on page 219, called generous listening, where you interview the patient and you listen between the lines, someone often calls it. You listen to decipher what is the patient's perception of the problem. You are listening without judgment or evaluation or offering opinions. So honing your interview skills is important. We're actually going to look next week, and I'm going to show you some materials from an international group called the IDA Institute. I think I've talked to you about it before. They actually have a whole series of videotapes to train people like you and me, professionals, about how to interact with their patients with hearing loss, and to take the perspective of the patient. So they have created a series of real people, real families, videos, and the idea is that if you let your patient tell the story, let that parent tell the story, let that patient tell the story, let that spouse tell the story, that you will learn a great deal that you can't learn by simply asking forced choice, yes or no, data-based questions. So we're going to take a look at some of those videos. But there are many SLPs, many audiologists, and others involved in AR who say questionnaires take a skilled interviewer, they take an empathetic, generous listener, and the quicker, faster way to get this is to use a questionnaire that asks specific information. And if you look in your textbook on 295 and 296 and 297, all the way over to 298, you will see a list of a large number of questionnaires, all of which are available online or in research articles that you can download. So these all are free, an important characteristic. But they are different questionnaires that are essentially self-report questionnaires that allow you to have the patient complete them and then quantify what are the problems that the patient talks about. In your textbook on page 311, there is the Hearing Handicapped Inventory for the Elderly. Make a copy of it and take it to your medical site. It's free. That is a quick and dirty way to assess the kinds of handicaps that elderly patients experience. So to quantify, it's 25 questions. Some of our elderly patients obviously can do that questionnaire. They can say, does this happen to me? Yes, sometimes, or no, or never. That's a way to quantify the problem that they are having. There's also one from Shao and Nirvan, the core and care folks, called the Self-Assessment of Communication, the SAC. And it's on page 312. Again, free. This self-assessment of communication sets up some situations and asks the patient, do you experience communication difficulties in these settings? Almost never, never, occasionally, some of the time, frequently, practically always. It also assesses feelings about communication. How do you feel? Does your hearing limit or hamper your personal or social life? And then there's also in your text on 315 the hearing handicap scale for adults, the hearing handicap inventory for adults, which again is designed mostly for working age adults. Same kinds of questions that are on the hearing handicapped inventory for the elderly, but a little different set of 25 questions. All of these obviously are in your text. You can copy them. They're free. They give you a way to quantify from the patient's perspective, what are the most difficult situations for me? How do I feel about my hearing loss? What is my perception of the amount of difficulty or the handicap that my hearing loss is causing for me? It allows you to gather general information, to target specific situations, to get a sense of your perception. So any of these self-assessment questionnaires, they are recommended by the American Academy of Rehabilitative Audiology. The last two I want to point out, number 5, called the COSI, I think I may have talked about before, the Client-Oriented Scale of Improvement. It's also in your textbook, and it actually asks the patient, tell me 5 situations that you would like to target as problem areas for you. So your patient actually tells you what to use as a therapy target. The life questionnaires are the listening inventories for education. They are recommended widely by educational audiologists, again, to do a listening inventory of children with hearing losses in school-based settings. So again, all of these things are free, which is a nice thing. It means we're not spending a lot of money to pay for diagnostic assessment tools, but they all have been vetted through research studies and other professional groups. So we do actually have a lot of special assessment tools to help us do a diagnostic assessment. Now again, one of the questions is, how helpful are these things that are self-report? They certainly give us a qualitative view to add to our audiometric test. They can help us move beyond just X's and O's, beyond decibels, to talk about, again, this functional impact of the hearing loss and to set individual treatment targets. Another tactic that we oftentimes use in our assessment that is an assessment strategy, but it's also the beginning of a therapy strategy. It's a daily log process. So these are self-reports of behaviors by the patient who is self-monitoring. The advantage to that is the patient might log the number of times a day that they experience a communication breakdown. Which settings did they experience a communication breakdown? By doing a log for several consecutive days, they begin to become more aware of their own situation. They begin to develop that ability to kind of self-assess, to target a specific situation. So again, individuals can perform that daily log activity either before they participate in some short-term AR communication strategies intervention, or before and after is a pre or post-test measure. But sometimes they just do that as a part of the initial step in therapy. You know, anything you measure, anything you count, makes you that much more aware, and you often change your behavior. How many of you have ever counted calories? Anybody ever counted calories? When you start counting calories, you begin to notice what you eat, right? You make perhaps healthier choices simply because you were aware, you counted, you were recording. And that's really a fundamental principle of behavior change. What we count, what we record, what we log, what we notice may in fact help us begin to make changes, or at least begin to analyze what is it that I typically have for breakfast. Maybe that's a place I could save some calories, or maybe I need to eat a more healthy breakfast so I don't gorge on calories later. Certainly graduate school is a terrible time to do that. Most graduate students don't eat and don't sleep well. They don't take care of themselves, and I'm going to be your mama for just a minute. I want everybody to promise me that in the next 72 hours before your comps that you take good care of yourself, that you consider sleep and eating well may be the very best thing you can do at this time. Any more studying or cramming is likely not to make a real difference. Wonderful. Sarah, I sometimes feel that way too. Professors sometimes don't sleep well or eat well. But do try to take care of yourselves. Again, sleep and eating well probably is going to do more for your performance on your comps than anything you can possibly do in terms of studying at this point in time. And that's a little kind of levity, sort of a way of thinking about this daily log idea. Does seem to, for many patients, when we're talking about making a behavioral change, wearing an amplification device, using a repair strategy, moving or changing the environment is really an important thing. And so I want to encourage you that while that seems sort of self-evident and sort of simplistic, and isn't there a magic test that we could give them, those daily logs oftentimes do help individuals self-monitor. They actually may influence how the person views those communication behaviors and breakdowns and those strategies. So it can be an assessment procedure simply so they see how often does this happen. what situations are most problematic for you, which partners are most problematic. But it also can be part of the training procedure itself, again, in terms of building this awareness. So again, you may want to think about the patient doing that. You may want, particularly in our skilled nursing facilities or our long-term care settings, think about having a caregiver complete that. Again, we're talking about quick and dirty. We may be talking about making X's on a chart rather than writing out something. So we want to think about really simple kinds of things. If you look on page 300 in your textbook, there's some examples from a daily log designed to monitor a person's communication behaviors, again, where it's check or where it's circle, never, a few times, many times. So you can make it as simple as it needs to be, again, considering the patient, the level of skill. Dr. Matlock and I actually have been doing a big research project that we've presented a whole lot of places. We presented in Italy, we presented in Vancouver, we presented at ASHA, we presented at ARA, and we've been doing it with students, and we've been using little icons, sort of emojis, of sometimes, never, always. So some of these kinds of things can actually be done with our young students or our older cognitively impaired adults. So it doesn't have to be elaborate, but it can track their use of strategies, their communication difficulties, how easily or fluently they communicated. Another assessment tool that Nancy Tamari discusses on page 301 is this idea of group discussion. So a group is a forum for individuals made up of several clients with similar characteristics to discuss their communication issues. These oftentimes work wonderfully well in our long-term care facilities, skilled nursing facilities, assisted living situations. So we're going to put all of the residents that we target for some sort of short-term group intervention together in a group. In that group itself, the individuals may have an opportunity to talk about what are their problems. And if you look on page 302 in your book, you'll see a table of common concerns that might be identified in a group. Talking on the phone, impatience on the part of a spouse, avoidance of old friends, others talking to my spouse but not me, feelings of incompetence and anger, difficulty conversing in noisy settings, difficulty communicating with my coworkers, frustration that my family doesn't understand my hearing loss. Again, each group will be different, but oftentimes there will be at least one person in the group who is more self-aware, better able to express feeling. Others are simply saying, I can't talk on the phone. Oftentimes our patients who are hesitant to acknowledge a problem, who are still bluffing a lot, who are denying a problem, once they're in a group and hear others acknowledge a problem, talk about a problem, talk about their feelings about the problem, they are more willing to come forth and at least acknowledge that. So oftentimes, in addition to the social support, I'm not alone in this. Other people have these kinds of problematic situations. It oftentimes helps the group to actually come up with interventions. It worked for me when I did such and such. At our house, we now don't try to talk unless we turn off the television and sit face to face. Again, that seems so simple, but oftentimes the group itself is a helpful assessment context, but also a beginning of intervention. So one of the things that you want to think about is, how could I conduct a group? Where can I conduct a group? So again, you clearly can adjust the time to suit the characteristics of your group. Many of these groups, if they are healthy adults, might last 60 to 90 minutes, might be once a week. They might be 30 minutes. They might be, if you're working with groups of school-age children, they might be an hour. So again, varieties of time, different numbers of participants, and more or less guidance or structure from the SOPs. Another completely different strategy for assessment is to use these things that are described in your text on page 303 called structured communication interactions. That's where you specifically set up a conversational context that reflects something that the patient has indicated, this is a problem for me. So you're simulating a conversation where you think, and the patient has acknowledged, maybe this is where a difficulty will occur that's typical of what happens in the patient. And so you as the clinician are monitoring and evaluating the problems as they occur. You are then talking about the problems that happen, talk about alternative ways of handling them, discuss what the information flow was, discuss which communication strategies to use. So there are a number of those more formal, structured interactions. That might be where you would do a mean length of turn ratio, particularly if the other participant was not you, the clinician, but was one of these frequent communication partners. Your textbook does talk about a strategy called Topicon, which is an activity or a strategy that evaluates conversational fluency, where you actually tally number of prolonged pauses, number of false starts, number of topic shifts, number of interruptions in a turn, making a judgment about the level of abstraction versus superficiality. So again, you are measuring some specific aspect of conversational fluency. The other option is to use these unstructured communication interactions, where you're simply providing an experience during assessment or maybe doing in therapy, where you're going to induce a breakdown so that you put the patient in a situation where there's an opportunity to use a communication strategy, or where you as the clinician can model and teach a communication strategy. So you're purposely inducing a problem. You're observing the patient's strategies, and then you're teaching them how to do that. There actually is a computer-based technique called Dialogue, again, a computer tracking software that can track these breakdowns. So you have the patient and a frequent communication partner engage in a conversation. Sometimes you provide them with conversation cards. Talk about what you did last weekend. Talk about a meal that you had. Again, you're analyzing data. The data in Dialogue, this particular software program, is looking at these kinds of things. Mean length of turn ratio, number of fillers, number of interruptions, number of communication breakdowns, different topics discussed. But you can do that without the software if you're doing that. And you can then obtain ratings from observers. Is this a good conversation, a smooth conversation? Is there a smooth flow on a rating scale from 1 to 4 or 1 to 5? So this computer technique can enable you to do that and save the data. So there are a number of different, the point is there are a number of different tools that the SOP can use, none of which cost anything except maybe some of these computer software programs. But essentially, most of the ones that we've talked about are free. They're either available online or in an article that's available online, or they're simply data that you collect from a communication sample. You can use those to assess conversational fluency and communication breakdowns, and whether they're interviews, questionnaires, conversational sampling with mean length of turn ratios, the number of breakdowns. Then each tool you can use in a battery approach to assessment. Most of the time, when we work with adults, we are looking for this quick and dirty kind of assessment. So we're looking for that Al Penner, Medlin, oral rehabilitation screening assessment with a little bit of information about self-report, a little bit of information about speech reading ability, a little bit of information about auditory discrimination or listening discrimination. If we see more of an issue, we may want to do the hearing handicapped inventory for adults or the elderly. We may want to do lip reading assessment, the Denver Quick Test, the Utley sentences. We may want to do an auditory discrimination assessment by looking at the lexical neighborhood test. We may want to do one of these communication sampling with mean length of turn ratios, tallying number of breakdowns, so that we have a pre-test measure. We have now a view of what our patient needs, and so we can design an individualized or a group intervention for our patients that are targeted to their specific issues or problems. Okay, everybody want to take a standing break for just a minute. Stand up, wiggle around, run get something to drink if you need to, and in 2 minutes I'm going to do a quick review for your comprehensive exam. This is essentially the information I talked about last week that I posted again for you. And I'm going to quickly review that, and then I'm going to quickly review the online midterm exam. Your midterm exam is online. It is open July the 5th through the 10th. So you have 5 days to take it. It is time, and I'll go over that. But let's take a 2-minute break here. Time for us to get started again. I'm going to quickly go through this PowerPoint that Dr. Smith had me create for a distance ed class to do a comprehensive exam review. I do not know which questions she and Dr. Gibson will choose to put on the exam. I do think that they will be primarily audiology-related questions and speech science-related questions about oral rehabilitation. I think if the case studies were to be clients where hearing loss was one of the factors, it would be simply one of the factors in a person who had Parkinson's, a person who had a stroke, some sort of traumatic brain injury, a child who had some other issues in addition to hearing loss. They tend to be, the case studies that Dr. Smith and Dr. Gibson choose tend to be complex cases in the sense that they're not just one problem with one specific solution. So I think you can always use core and care as sort of your template for what should I talk about? How should I address the assessment for the client? The others that should be involved with the client in terms of referrals or in terms of others on the IPP, the Interprofessional Practice Collaborative Team. Again, back to what we have already talked about a million times, I think, and actually reviewed earlier this evening, this idea that AR is an ecological interactive process, that we are looking to limit the auditory dysfunctions across a whole range of possible impacts. So it is a much more holistic approach to therapy than perhaps we are used to thinking about when we think about writing a treatment plan for a speech sound disorder or for a language impairment. It is intervention aimed at minimizing or alleviating the communication difficulties associated with the hearing loss, because we can't cure the bodily function. We can't cure the hearing loss. So we are focusing on the participation limitations, the activity limitations, and how to address those. So when we think about what might be on the comprehensive exams in terms of the kind of questions, it is going to be these important terms, the basic models of assessment, core and intervention care, the specific assessment tools in Chapter 2 that we've talked about more of them tonight, intervention procedures, the idea that counseling is a significant part of oral rehabilitation, and that we have to be very acutely aware of cultural differences and cultural implications. We have to look at different communication modalities. That's why the communication modalities project that you and your teams are doing is especially important, looking both at the technologies, hearing aids, cochlear implants, BAHAs, hearing assistive technologies, assistive listening devices, and looking at communication modes, ASL, manually coded English systems like C signs, looking at simultaneous communication, looking at auditory only or auditory verbal approaches, looking at oral approaches, or looking at simultaneous communication strategies or total communication strategies, and looking at this idea that auditory processing disorders are rare, but they certainly do occur. And as SLPs, we are likely to be the treatment specialists who are going to address the problems that both adults and children with auditory processing disorders actually experience. So here's some important terms. I would suspect that there may well be a question about each of these. You will want to look in your textbook at the glossary and look at the marginal notes that will help you define each one of these terms. So you do want to be thinking about those terms. I think we've talked about all of them except continuous discourse tracking. It should be TRACKING. It's in your glossary. We're going to talk about it next week. It is an oral rehabilitation technique where the listener attempts to repeat verbatim the text that the sender, the speaker, is presenting. And you summarize that performance in terms of the number of words repeated per minute. We use it as a measure of how effective is our client in deciphering the message. So it's presented auditorily and visually. Oftentimes we do something like read a newspaper article, read a familiar story, read a magazine. So we are literally presenting verbatim conversation or a monologue, and our patient is literally repeating it after us. How much of it did they get or decipher? So it's continuous discourse, and our patient is tracking us by verbally repeating verbatim the text. and we're simply measuring how many words did you get right. All the rest of those I think we've talked about. Anybody see one that they don't know what it is? Again, the glossary on your textbook, I think, ought to help you with that. Again, the models for answering the case study questions are CORE and CARE. If you sort of follow through that, it's going to lead you through the diagnostic identification process and the intervention process appropriate for persons with hearing loss. And it's going to include the things that will be in the stem of the case study. Tell us the assessment procedures. Tell us the appropriate intervention plan. Make sure you talk about appropriate referral sources or additional information so that it's a team-based approach. Again, just make sure we've reviewed this again tonight. So just make sure that you're familiar with CORE and CARE and kind of have those in hand so that you can use that as your outline to answer the assessment question on a person who has a hearing loss as one of the components of their communication difficulty or disorder. Again, CLEAR, we did talk about tonight. Here's a quick and dirty 1 hour management strategy for clients. If there's nothing else that you can tell a person with a hearing loss in terms of how to manage your hearing loss, how to live well with your hearing loss, it's use CLEAR. Control your communication situations. Look at or lip read the talker. Make sure your expectations are realistic. This is not going to be 20/20 hearing like you remember. Parents, this is not going to be normal hearing for your child. This is going to, you have to keep in mind the hearing aid age, meaning when did your child receive full-time amplification, whether that's through a hearing aid or a cochlear implant or a BAHA, including assistive listening devices. Working on assertiveness in terms of helping others who are your partners understand your hearing difficulties and how they can help you best, and using repair strategies when there breakdown. If there's nothing else you can do for patients who have hearing loss outside of some brief counseling and information giving, give the partner speech. Speech is, again, another little acronym, a technique. Here's what you do to make the communication situation with your hearing impaired significant other easier. Spotlight your face and keep it visible. That's purely an emphasis on speech reading helps. Auditory visual integration is real. The McGurk effect is real. Pause between thoughts, because that's where the processing occurs. So for any of our patients who have processing problems, processing speed problems, that pause between thoughts is important. Not slow it down so that you distort, but that at normal pauses between phrases, pause a moment. That's that several seconds, milliseconds, where processing takes place. Emphasize, be patient, and rephrase. If your partner doesn't understand, try rewording or rephrasing. Sometimes some words are easier in terms of the density of their lexical neighborhood. Remember, we talked about that. Maybe you will choose a word if you just rephrase that is in fact easier for your partner to either hear or speech read. Ease the strain of listening by getting attention first. Call their name. Practice slant. Control the listening environment. One of the most important things is this environmental control. Reduce the distance. Eliminate as much noise as you can. Look at context where you reduce reverberation. So carpeting, tennis balls on the bottoms of desks and chairs, soft materials on the walls, other furnishings that reduce that reverberation. So it's distance, reverberation, and noise are the problems that we see in hostile acoustic environments. And have a plan. If there is a breakdown, what am I going to do? How am I going to change something? So again, assessments. I simply listed a whole bunch of assessments. So rather than saying, I don't know any assessments to do, we've actually talked about almost all of these. The one that we are going to focus on, not this upcoming week, you're going to do your comps and take a little break. But next week, when we talk about counseling, the discussion activity is for you and a partner. That means you and a spouse, you and a child at home, you and a friend, you and a coworker, you and a neighbor, you and someone else are going to practice the CID everyday sentences, the Central Institute for the Deaf everyday sentences. They are in your textbook on page 79 and 85 through 85. I mean, we've already looked at them. They are a general list of 10 different lists of everyday sentences. Good morning. How are you? That you can use as stimulus material. That's what they were used for. They were materials to be used for speech reading, for auditory visual integration, to make an assessment of hearing impaired individuals. They are so simple that they certainly can be used with older children. Again, even children who have a fairly significant hearing loss. Obviously, they can't be used with children with very limited vocabulary, so they're not appropriate for our very youngest children with hearing loss. But there are sentences like, good morning. Here's a nice quiet place to rest. It's time to go. I'm sorry. Time's up. Music always cheers me up. So it's that type of everyday sentence. There are 10 lists in your, so you don't use the same one twice. But that's a great tool, and you're going to use that as part of an activity where you're going to be the speaker sometimes and the listener sometimes. And I've set you up a little simulation that you do with your partner where sometimes it's quiet and you have full face clues and good voicing. Sometimes it's noisy, there's background noise. Sometimes there are no visual clues. And I want you to experience both roles. I want you to be the speaker and I want you to be the listener. Some of you will be wonderful speech readers, and it'll be easy for you. Others of you, I bet, aren't so good. I'm not very good either. When you are the speaker, some of you will go, this is just a game, I just have to do this so I can write my discussion post. And others of you will go, well, why didn't he understand? And they'll say it again, and you say it again, and the person still doesn't understand. And you begin to get a sense, I hope, of what it's like to be the spouse of a person with a hearing loss, to be that CNA in a skilled nursing facility or a long-term care facility where Mr. Brown never understands anything you say to him. You have to yell at him all the time. Or a parent, I'm so tired because I have to repeat everything for my child. So I want you to get that sense of frustration, maybe anxiety. I want you just to sort of have that experience. Again, not until next week. It's our discussion activity that relates to counseling. But we're going to use those CID, everyday sentences, as our stimulus. We're going to do them auditorily, we're going to do them visually, and then we're going to do auditory visual, the normal mode. The auditory training assessments, we talked about LACE, computer assisted program. We talked about Spth. We talked about the CAST, Ertmer's auditory training in a box. We've talked about communication strategies used. We've talked about these hearing handicapped self-assessments. We've talked about the client-oriented scale for improvement, the COSI, the SACS, the self-assessment of communication. We will talk more after your midterm, and I promise it's not on the comps and it's not on the midterm. We'll talk more about language and literacy assessments for children with hearing loss. We have talked about some about speech. We've talked about using Daniel Lean's 6 sound test. Dr. Lean also developed a speech assessment for hearing impaired individuals, a phonetic level assessment and a phonologic level assessment. I gave you that handout from an ASHA training on using audiological information and speech assessment and how they go together. And the example that the SOP used in that little scenario was the Goldman-Frisco test of articulation, which we certainly can use with hearing impaired children, particularly those with mild and moderate hearing losses who are making good progress in terms of verbal skills. You do want to be thinking about management of these amplification devices. Multiple memory hearing aids are the state of the art, where we are able to tailor a hearing aid's response to specific listening conditions. So a tailoring of the hearing aid for the listening condition of quiet, a listening condition of noise. My husband had his hearing aids tailored to a situation for listening to music. So again, multiple memory devices, bone-anchored hearing aids, cochlear implants, assistive listening devices like FM systems, or hearing assistive technologies like telephone relays, like computer-assisted real-time captioning, which is a version of the stenographer who is doing speech to text, and our hearing impaired adults and children can actually see on a computer screen what the words are that a speaker is producing. You want to be thinking about speech reading and auditory training, those analytic versus synthetic approaches, that formal instruction where you do guided learning and real word practice, and this idea of continuous discourse tracking task that we just talked about. You want to be thinking about auditory training hierarchies and what makes speech perception difficult. You want to think about the differences in vowels and consonants. You want to be thinking about the hard vowels, or those vowels where the second formant may not be perceptible to the individual because of the severity of their hearing loss, or where there is no difference on the first formant, the difference is in the second formant. You want to think about consonants that differ in nasality, manner, place, and voicing, and that place cues are the hardest to discriminate. Again, you want to think about the elements that make a task easy versus hard, closed and open sets. You want to think about communication strategies, training for clients and the partners, using those facilitative strategies, those anticipatory strategies that hopefully prevent problems, but also recognizing that there will be breakdowns and we have to have repair strategies. Again, you want to pay particular attention to Erber's auditory training task continuum that we talked about, that this is the general sequence for all clients. Are they aware and can they detect sound? Can they discriminate two sounds are the same or different? Can they identify a sound with a label? And can they comprehend longer segments of auditory stimuli? Again, we'll talk more about the Ling phonetic and phonological speech assessment because it's one designed specifically for those children with severe and profound hearing losses who are not just learning good articulation skills because they now have a hearing aid, a cochlear implant, a BAHA that gives them near normal hearing, and they're learning speech and language through the auditory only method in incidental learning. So Dr. Ling said even children with severe and profound hearing losses can develop good functional speech with well-designed intervention. And we're going to talk about that. The first thing that he always says is to avoid deafy speech, that monotone or nasal speech with central vowels only and a few visible consonants. To avoid, I have hearing loss. That is deafy speech. To avoid that, we as SLPs have to first focus on suprasegmental features of speech. So we have to develop in our hearing impaired children from very early good voice quality, appropriate inflection and intonation, the ability to change pitch, the ability to easily, quickly, and automatically combine consonants and vowels. And so we do have to do a lot of drill and practice at the phonetic level. So we do ba, be, boo. Again, I use that as a euphemism for drill and practice on consonant-vowel combinations with different inflections, intonation, pitch, loudness, and intensity. And then, once the child can easily control their speech mechanism, then we move it to real words, phonologic level. Now that's real words might be uh-oh, or good. So early on, we do use real words, but we only demand good speech real words where we know that the person has control over the suprasegmental features of speech and these basic consonant and vowels at the phonetic level. Again, we'll talk more about it. Counseling, we're going to talk about next week. Counseling for the patient, counseling for significant others. Informational or educational counseling, we're all comfortable with that. We do that all the time. We like telling people about things. You did a whole discussion activity. We talked a lot about being able to explain the audiogram to the patient and significant others. But we also do personal adjustment counseling, adjusting to your hearing loss, accepting your hearing loss, being able to live well with a hearing loss. So we do this personal adjustment counseling, rational acceptance counseling. We do assertiveness training, learning not to bluff, learning to be assertive and help others understand what you need as a person with a hearing loss. I need you to turn around and look at me. I need you to turn down the television. I need us to move to a quiet room. I need you to repeat that. I need you to tell me what the topic is that we're talking about before you just start introducing a new topic. So being able to help others meet your needs is part of this assertiveness training. Psychosocial support, recognizing that all of our patients, from our young students to our older geriatrics, need psychosocial support. They need support from peers. They need support from significant others in their living setting. We will do more talking about parent-child issues in early intervention. The federal law that provides newborn hearing screening and early intervention is called EDI, Early Detection and Hearing Intervention. It's a federal law that gets reauthorized every 5 years. Hopefully, when it comes up for reauthorization, the current administration will support it. But it does provide assistance to states to actually implement newborn hearing screening and early intervention programs, particularly family-focused intervention that supports the parent's right to choose the communication modality for their child, that it's not the professional's choice. If the parent prefers ASL, if the parent prefers auditory verbal, if the parent prefers cued speech, our job as professional is to at least support the parent choice. It may not work. You may believe as a professional it won't work. It's not the best choice. But again, your ethical responsibility, according to ASHA, is to support the parent in making that choice while providing them with honest, accurate information about the range of communication modalities that are out there. And certainly you can provide your opinion based on your professional judgment and your knowledge of a particular child's constellation of factors, what would be most appropriate. So it's a balancing act. But you want to make sure, and in your communication modalities project, you want to include these: cued speech, American Sign Language, total communication, that use of anything and everything, sign, finger spelling, oral skills, auditory information, manually coded English, oftentimes abbreviated as MCE, meaning using some of the signs from American Sign Language along with signed cues for inflectional markers, so it's seeing essential English or signing exact English. It's not a language, it's a made-up language, so that individuals, particularly children with hearing loss, can learn to read and write more effectively. Visual phonics, an approach where we actually teach people with hearing loss visual symbols to enhance their ability to learn the alphabetic principle so they can learn to read. Bilingual bicultural, the bye-bye approach, the approach where we talk about children who learn American Sign Language as their home language because they come from a family for whom ASL is their home language, that then when those children come into an educational setting, they are like other EL children, where they learned one language at home and now they're learning English in school. So it's bilingual and bicultural, and we use some of the techniques from that approach to teach English as the second language, oral English as the second language. Auditory verbal, the AVT, auditory verbal therapy approach, which focuses intensively on learning language through the auditory modality, up to and including reducing visual clues, using the auditory hoop or the auditory screen to train children to maximally use their audition, in contrast to auditory oral approaches that are going to use audition plus speech reading clues, natural gestures, focusing on oral speech, but using a more auditory and oral speech reading approach. We want to talk, and again, I'm going to, at the very end of this course, I'm going to talk some about auditory processing disorders. Dr. Matlock did a review for you in audiology from the audiologist's perspective. What are auditory processing disorders? Here is the definition, that we do use a team-based approach where the audiologist helps us define the location in the central auditory nervous system where the deficit is. The audiologist recommends amplification or FM systems if that is indicated, but that the deficit-specific interventions that are oftentimes provided specifically for children but also for geriatric patients are frequently conducted by the SOP. That could be done by the audiologist, but because the audiologist is not in the school on a regular basis, not in the skilled nursing facility or long-term care setting on a daily basis, it oftentimes falls to the SOP. ASH's recommendation is that we use what is called the three-legged stool approach, or the tripod approach, that for individuals with diagnosed auditory processing disorders, we first look at environmental management, where we manage distance, reverberation, and noise level, the signal-to-noise ratio, oftentimes through classroom amplification or personal FM systems. We look at lighting, we look at number of different speakers. So just like the core and care model, it's environmental management first. We also use compensatory strategies. So we do accommodations and modifications and compensatory strategies in the classroom, in the listening environment of our residents. And then the third leg of that stool is direct remediation activities, therapy approaches, both top-down and bottom-up, both analytic and synthetic approaches, sometimes including computer-assisted drills. But it's the idea that this is a three-legged approach plus a team-based approach. The audiologist, the SOP, the significant others, and the client. We also work on self-advocacy. That, again, this idea that the patient, the child, the adult, has to be able to advocate for themselves. And so actually the approaches are really similar for our children, our geriatric clients, our veterans returning from the battlefield where they experience auditory processing disorders as a part of various traumatic brain injuries. The similarity of the approach is significant, I think. So again, it's always this coordination. It's always this interprofessional team that we have to be collaborating with other service providers, and that the most important member of that team is the family or other communication partners in addition to our patient. Okay, can everybody hang in there quickly? That's the comprehensive exam. That's everything there is to learn in this course, but you already all know. This is about your midterm exam, which will open July the 5th online in eLearn, and it will be open through July the 10th. So again, 5 days to take it. It's a 2-hour exam, unless you have an accommodation and then you have special access with extended time. But make sure that you study before you go in. You can't go in and come out. So make sure you're ready to take it and then take it. Make sure you give yourself enough time, if you wait till July the 10th, that you can complete it before it closes, because it will close at midnight, July the 10th. So it's 2 sections. One is an objective session of multiple choice, fill in the blank, matching type definitions, and characteristic questions. Very much like the end of the chapter questions from your Time Murray text. So pull out your end of the chapter questions. Pull up my feedback to you in the Dropbox, where I said, thank you for submitting these questions. Pay particular attention to, and I listed again, that's another kind of cue. If I listed it as something important, it might be going to appear on this midterm exam. In addition to that, there are a series of long answer essays. Now, long answer means long in the eLearn sense. I had to give you a text box that gave you plenty of room to write. So it will be questions like describe, explain the goals, describe the advantages or disadvantages, compare and contrast. So those kinds of words. On major principles of AR service delivery, auditory training and speech reading approaches, the SOP role in informational counseling, interpretation of the audiogram, speech perception and vowel formants, how to check a hearing aid or other amplification devices, and the essential elements of core and care. So those are some heads up about what those essay questions might be. You're responsible for the text materials, chapters 1 through 10. I will do an archived online lecture on what would be next Wednesday night, the 5th, on chapters 9 and 10. I'll make it before the holiday weekend, after your comps. You may go in and listen to the archive and take your test on Wednesday, July the 5th if you want. If you say, I need a break, I've studied hard for comps, I'm going to put this off, you do not have to come to a synchronous class on July the 5th. You can listen to that archive lecture at your leisure, but you must listen to it before you take the test. Does that make sense? Everybody got that? Because 9 and 10 will be on the test. I'm trying to give you as much leeway as I can for you to accommodate both your 4th of July holiday plans, getting through comps. So don't go take that test until you've listened to the archived lecture, but you don't have to come to class next Wednesday night. Everybody got that? Okay, so you kind of get a little break. So your test will include chapters 1 through 10 and selected parts of 15. You remember you actually read 15 the first night of this class. It's about school-age kids, and it's about those communication modalities. It's about the impact of those basic degrees of hearing loss. The part of your text that is pages 652 and 653, that little handout that was originally developed by Madkin and Flexer. It's been published in every AR text, every book about hearing impaired children that looks at degree of hearing loss, what are educational needs, what are psychosocial impacts. So make sure that you look at that one. Look at that communication options materials of those different communication modalities. Again, that's pages 562 to 568 in your textbook. Make sure you know the difference in ASL, cued speech, manually coded English systems. Make sure that you know core and care. Make sure that you know the Ling 6 sounds functional check. What are the sounds that you use? Make sure you know why you use those sounds, because they cover the speech range. They cover the basic elements of the speech banana. So you want to make sure that you think about that. As you study, you want to remember that literally this test mirrors the objectives on your syllabus. So the objectives on your syllabus are actually the ASHA CCC's requirements for communication modalities and hearing loss. So it's about analyzing the acoustic bases of communication disorders. So the characteristics and consequences of hearing loss based on that Educational Audiology Association relationship of different degrees of hearing loss. The familiar sounds audiogram, the count the dots audiogram, the Ling sounds and speech science. You all have had so much of that in the last month Dr. Matlock has inundated you with it. I've inundated with you. I think you'll be just fine. You also will be responsible for the learning objective to explain the nature of hearing disorders across the lifespan, including their developmental and linguistic characteristics. Again, that EAA handout gives you a synopsis of that characteristics and consequences of hearing loss from Chapter 1 in your book covers that. The development of auditory and speech reading skills, and that clear that we talked about tonight, and speech as the quick and dirty summary of auditory rehabilitation or audiologic rehabilitation for partners and for patients or clients with hearing loss. You do want to be able to think about and synthesize the psychosocial, educational, vocational, and cultural implications of hearing loss. And you want to think about communication strategies training, Chapter 9, and the counseling issues, Chapter 10. So that's why you want to listen to the archived lecture on Chapters 9 and 10 before you take the test. Students will, and to turn in your chapter questions for Chapters 9 and 10 next Wednesday, the 5th. So that you've looked at those. You do want to make sure that you can, again, know these communication modalities or communication approaches. Auditory, verbal, sometimes that's called the unisensory approach, meaning the focus is on the one sensory modality of hearing. Hearing is what's important. We're going to focus on hearing. We're going to build hearing skills. We're going to use audition to learn speech and language. Oral methods focus on listening, but also on speech reading and using other speech interventions to improve the oral communication skills of people who are deaf. Cued speech, the various manual modalities, finger spelling, total communication, the manually coded English system, the ASL, the bilingual, bicultural approach, the Tadoma method. The Tadoma method is actually named for two deaf kids, Tad and Oma. They were deaf-blind kids. And a method to teach these deaf-blind children was to finger spell or sign in their hands. Those of you who've ever watched the movies about Annie Sullivan teaching speech and looked at that process, how do you teach a person who's deaf and blind to understand communication? So Helen Keller and Annie Sullivan, obviously, are an example of that. But the Tadoma method was a much more explicit method learned by SLPs, teachers of the deaf, to teach these children who were deaf and blind. And then they call that method the Tad Oma, the two little children's name, and called it the Tadoma method. But it's about deaf blindness. So you want to be looking at those. Again, I've given you the actual pages in the text that you want to make sure you review. Also on the midterm will be questions about various electroacoustic instrumentation. So you want to study those components of the hearing aid. This is Chapter 3, the components of a cochlear implant. You want to look at FM systems and other assistive devices. You do want to be studying the steps in checking a hearing aid. You want to look at how to functionally monitor those instruments, and we went over that when we talked about Chapter 3. So the visual check and the listening amplification check. Again, you want to be thinking about how do you design collaborative AR oral rehabilitation, oral habilitation programs. You want to think about the sequence of speech reading objectives, the sequence of auditory training objectives, those hierarchies, and which is easy, which is hard. The exam will be open in eLearn from 6 a.m. on Wednesday the 5th to midnight on Monday the 10th. So again, you have 5 days. You have 2 hours to complete the exam once you log in. I will need to hand grade many of these items. So this is not all multiple choice, true, false, and you just get your grade. I'm going to have to do a lot of reading, regrading, hand grading, so your score won't reflect your full points. So it's going to take me about a week after you all finish to grade everything. But once you finish the midterm and you finished your comps, you just breathe a big sigh of relief, and you know that we will get you feedback back. I want to wish you good luck as you prepare. I am sorry that I am not going to be with you all on Saturday. My family had a previous commitment made at the Christmas time, the winter break, for a family reunion with lots of people that I am absolutely committed to go to. And then when Dr. Gibson announced that she would prefer to have the comps on this weekend, I had already planned to be on leave. So I will miss being with you. I do have a little surprise at your celebration, Dr. Smith and I've talked about. So you have a little surprise for me that will be waiting for you at your celebration. Again, I'm sorry that I won't be with you, but I know that you will do well. I'm confident that you have studied. I do want to encourage you to get plenty of sleep and to eat well, and to take a deep breath. You've worked very hard. You are really to be commended for the hard work that you have put into this process. For many of you, we know that it's been a challenge for you, but also a challenge for your families. And we are more than knowledgeable about that, and we again are so excited for you that you're graduating. Those of you who will be graduating in December, we are equally looking forward to seeing you graduate then. But please know that I'm thinking of you. I will check in online even while I am gone on leave, and try to monitor any problems that occur or any issues that you have. I know that you need your sleep, so I am going to let you go for tonight. Again, if you have questions about the comps or you have questions about the midterm online, feel free to email me, and I will try to get back to you quickly. You do have chapter questions 9 and 10 due next week, Wednesday. There is no discussion. That discussion about doing the little simulation with the CID, everyday sentences, and a partner of your choice is an individual activity, but with a partner. It's not due till the next week. So study hard, but then enjoy your 4th of July. It will be time to celebrate. Good night, everyone. and good luck. Good night, everyone. I'm happy to answer any questions, but if there are no questions, any questions that I can answer. Good night.